morning, everybody. My name is Eric Chaconis. Welcome to the PT on Ice Daily Show. I am one of the lead faculty for our extremity management course, and that course is all things exercise prescription and progressions, 2 days, manual therapy techniques for all the extremity joints. It's a lot of fun, very interactive, very lab-based course. Extremity team has grown a lot over the last year. Now we have both Lindsay Huey and Mark Gallant teaching that course. They're both lead faculty in the extremity management course. They both have a lot of opportunity. You have a lot of opportunities to take that course with both Mark and Lindsay coming up this year. I can't say enough good things about the way that they teach that course and the skills that they have. Mark and Lindsay are both fellows of AOMP. Lindsay's completing her Doctor of Science in Physical Therapy right now at Felon College. That's the program I work for. So I get to work with Lindsay on a regular basis, know her really well. She's a private practice owner in Delaware, amazing clinician, really great teacher. She does a great job with the course. Mark is from Richmond, Virginia. You've seen both Lindsay and Mark on this show before, but Mark owns one of the Onward clinics in Richmond, and he is also an amazing teacher. Mark's probably one of the smartest PTs I know. He's very analytical, very, very knowledgeable, really strong, especially in his exercise base and the way that he's able to teach kind of these exercise progressions and stuff, which is a lot of fun. So anyway, catch us in 2021. Lindsay will be in Orlando, Florida in May. Then she's in Nashville, Tennessee in the fall. I know Mark's in South Carolina in the fall. They have another one in North Carolina and Denver this fall. So we still have a few open dates for 2021 if you're looking to host extremity management. I got a lot of feedback over the last year. There aren't enough extremity management courses. You're not getting to enough places. It's very hard to take this course because it's not offered at the same frequency as a lot of the other ICE courses. And so we've corrected that by having Lindsay and Mark kind of help us out and do a bunch. And then we're also booking for 2022. So if you're interested in hosting for next year or later this year, reach out to us, please. All right, so today's topic comes from a recent study just published in the Journal of Shoulder and Elbow Surgery. This is surrounding the PT versus surgery topic for rotator cuff tears. So the title is Operative versus Conservative Treatment of Small, Non-Traumatic Supraspinous Tears in Patients Over 55 Years over a 5-year follow-up from a randomized controlled trial. So this group is out of Finland. They have published the results of this study, the 1-year follow-up, and I believe it was either the 2 or the 3-year follow-up prior to this. This is now the long-term follow-up, which is a huge gap in the literature. We do not know and understand comparative effectiveness of these different approaches, PT, exercise versus acromioplasty versus rotator cuff repair in the long term. And so this is a really nice addition to the literature on this topic. And I'm really interested in this personally because for me, I think, what I see is a lot of the status quo is for people to kind of default. I have a rotator cuff tear. It needs to be repaired, right? As soon as they hear the word tear in their mind, they think that needs to be surgically repaired. And that's probably not always the case. I just think more common than not, especially where we are in the United States, that's kind of the default. So it'd be nice to disseminate the results of these studies so people have a better understanding of current evidence and current science when it comes to sort of decisions. And I don't want this to come across as anti-surgery. I mean, I think as we dive into the results of this study, I want to highlight the fact that I personally, and I'm sure all of you have had a lot of patients do really well after rotator cuff repair. It was probably the right call, right? In a lot of cases, it is the proper call, and it does have good efficacy, and it can help people recover when they might not have otherwise. I just think, generally speaking, the public perception is inaccurate about what we know from the scientific literature, and people kind of default to surgery when maybe the default should be exercise and rehab, and surgery should be more in the unique scenarios. So it's just a matter of using the evidence to sort of help the public understand current best science. So what they did is they compared outcomes from a group that just got rehab, just physical therapy, versus a group that got rehab, that same program, and acromioplasty, versus a group that got acromioplasty, rehab, and also when they were in there, sutured the rotator cuff, so rotator cuff repair, right? So 3 distinct groups, very well-designed study with randomization, pre-hoc randomization. So it's neat to see stuff like this coming out here, right where we are right now. And you'll notice in Facebook, I posted a link to the Cochrane review from 2019. Where we are right now, we understand surgical versus PT, outcomes research much better than we did at any time point before this, obviously, right? So there's a lot of emerging evidence, and I think this is a topic you're going to start to hear a lot more about. So here's the theory. This is the theory behind it. These isolated full-thickness supraspinatus tears, these are smaller tears. These are not the massive tears that spread down into infraspinatus that retract all the way back. You see all the supraspinatus atrophy and retraction. This is not that scenario. This is more the small, isolated, full-thickness supraspinatus tears. But the theory is that they will degenerate more and more over time if you don't repair them. So they start small, they increase in size over time, and if left untreated, you're probably going to have more glenohumeral joint osteoarthritis, right? The joint mechanics are going to be such that the osteoarthritis onset will occur earlier because of the cuff tear. So not treating them or having them just go through rehab, the theory is that's not the right call because you're going to get more atrophy, more degeneration, and more pain and problems and loss of function later on. So it's sort of almost like catch it early type of a theory, which is really what this paper is trying to explore. And the truth is, we really don't know. That's totally a theory. We don't know. The evidence does not suggest that. We don't have any science that tells us that that's the case, that you're preventing more degeneration, atrophy, retraction, and more glenohumeral joint osteoarthritis later on when you catch it early and repair it early. So when we look at outcomes and we look at rehab only for isolated full-thickness rotator cuff repairs, we do know that those patients do well, actually. They see about a dramatic improvement 2 months in pain and functional improvements. That kind of tapers off and levels off after 2 months, as you would expect, but they do get better. So rehab only for full-thickness tears can be effective. The question is, when you compare it to surgery, which one performs better? And we know in the short term, there's no difference. The 1-year outcomes, there's not a significant difference. The key question here is, what about the long-term outcomes, the 5-year, or even in some cases in this study, they were followed after 6 years, 6-year outcomes. So that is the gist of this. 180 individuals, symptomatic, isolated, full-thickness rotator cuff tears that haven't fully degenerated, haven't fully retracted. These aren't the large, massive tears. All these individuals are over the age of 55. So these are the older, degenerative type of tears, not traumatic, injury-related rotator cuff tears, the ones that occur more over time, right, in the population that's over the age of 55. All these patients were referred to the surgeon. They got the MRI. The tear was diagnosed and confirmed via MRI, and then they get randomized to one of those 3 groups. That's really cool about this study, is that pre-hoc randomization, which increases the internal validity, right? The patient is, it's a blind randomization process. The patient knows what procedure they got. The intervening clinician knows what procedure they're delivering. Obviously, you can't blind to that, but randomization in itself is controlled and blinded. So the PT-only group, it's 10 visits with the physio, and it's primarily a home-based program. So those visits are like check-ins to progress the exercise program. It's primarily an exercise-based program. They start with periscapular training, sort of progress to cuff training and more advanced, typical rehab program that occurs over the course of 12 weeks. Then it's another 6 months of monitoring while they're in the program, and then they follow them after that with just outcome measures, right? They're not treating them after 6 months. So typical 12-week PT program, 10 visits. That second group gets the exact same PT program after they go under the knife for the acromioplasty. So acromioplasty, they go in, they shave the undersurface of the acromion, a typical subacromial debridement. They do a biceps tenotomy if the long head's involved. They debride the undersurface of the AC joint. If you have those osteophytes on the undersurface of the AC joint, they resect those. And basically, it's a clean-out procedure, right? That's all they do. No rotator cuff repair. Then PT afterwards, same as the first group. Third group gets the exact same thing, acromioplasty, all of those same procedures, plus they repair the rotator cuff tear. So interesting, in that acromioplasty group, they're going in. They see the cuff tear. They see that it's there, but they're not repairing it. They're only doing the subacromial decompression. This third group gets the repair. It's either a single row suture technique if it's a smaller tear. The slightly larger ones get a double row if that's indicated. But they are anchoring the cuff back down and suturing it with non-absorbable sutures. Typical rotator cuff repair, right? That's status quo in the United States. Everybody in my world, everybody I see gets a subacromial decompression, rotator cuff repair, and then rehab, right? That's kind of very typical. So that third group is a very typical group. So then they measure function, pain, and glenohumeral joint osteoarthritis with imaging over time. No difference between groups. No difference. No statistically significant difference. You see like a 1 or 2% difference in functional scores, pain scores, and stuff like that. But there is none of that meets statistical significant difference. And when you look at responders, number of responders, they're the same between groups. So, it's again another one of these studies that shows doesn't really seem to matter whether you get exercise and rehab or surgery and clean out scopes and repairs or whatever. It doesn't seem to make a difference in this case in the short term, in the 1 year mark, but also at the 5 year mark. A lot of these patients were followed at up to 6 years and didn't see a difference. They use x-rays, radiographs to look at post-treatment osteoarthritis onset. So at that 5 year mark, they do another x-ray, and they don't see a significant difference between groups in joint changes. So the joint is not degenerating faster in the group that doesn't get the rotator cuff repair. So that's pretty interesting. Kind of one of the first studies of its kind to really look at that. A few patients did cross over. They were in the rehab group, weren't happy, and ended up getting surgery, but that number was really low. It was only 16%, so it didn't make up enough of a portion of that group to be statistically significant. So I think there are some limitations that you need to acknowledge, right? The sample size is a little underpowered. Maybe you have 180 people spread out across 3 groups, and maybe there's a type 2 error there. Maybe if we had a larger sample of a really robust large group of people, we would see some of those differences would meet statistical significance. But these results are consistent with that 2019 Cochrane meta-analysis that's looking at 1,000 patients. So at face value, those results, you certainly could interpret them with decent validity. I think one of the most interesting elements to this study, and when you look at table 2, and I think this is a really important thing to do when you read studies like this, is get a solid understanding about the type of patient in the study. What's the mean age? What's the duration of symptoms? What are the severity of symptoms, severity of their condition, level of functioning? And, when I look at studies like this, sometimes I think, well, there's no difference between groups because everybody is relatively subacute. They all kind of get better no matter what. The level of function and pain isn't that severe. That's not the case. These individuals, the duration of symptoms in this cohort of people, most of them had pain for 20 months. They had a 20-month onset. So over a year and a half, I have not seen a lot of non-operative rotator cuff tears. Now, I'm sure some of the people I'm seeing, we never got an MRI, so we don't know. Maybe there is a cuff tear. But to have a cuff tear for a year and a half and have that then, recover with rehab at the same rate as surgery, I think is pretty impressive. So it's pretty cool to see results like that. And again, the choice of electing to have surgery is very individualized. Many factors need to be considered. I don't think that we want to go out there and, we're not talking every single person out of getting rotator cuff repairs. That's not what we should do with this information. I just think, generally speaking, why don't you try PT first? A PT first model is clearly not harmful, clearly doesn't negatively impact outcomes, and clearly a lot of people are going to get better and avoid that costly and painful and arduous post-operative surgical process that isn't without side effects, right? So a little safer, a little less expensive. Perhaps that might be the first choice when you're diagnosed with a rotator cuff repair for some people, right? All right, that's all I got for today.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.